Hello, Nick Entsminger. Again, honored to give a lecture to APP Virtual Lectures. Today's on the approach to resistant hypertension. This is going to be a review of potential options for patients that are resistant to the standard medications that we often give them for their hypertension. This is very common, especially with patients with chronic conditions, and often there's not a clear guideline on how to approach these patients as far as how to continue their care. I have no disclosures. The main objectives of this lecture is, first of all, I want to define the different hypertension types. Now, we all know stage 1, stage 2, we know essential, we know secondary, but we often don't know exactly what that means. And also how to define the different things like what constitutes a hypertensive emergency versus a hypertensive urgency. We often see those names thrown about, but we don't exactly know what the definitions of those certain titles are. So I kind of want to review that. Also want to go over the common causes of potential resistance. A lot of times it's some things that we don't necessarily see that we can address, whether it's not the patient's not actually taking the medications appropriately, maybe it's due to certain medication choices. Those are often causes what they call pseudo-resistance, and it's not actually hypertensive resistance. Also want to go over some of the use of diagnostics to try to figure out potential secondary causes of resistant hypertension, also to use these diagnostics as a means to not only diagnose potential underlying causes, but also note the significance of potential other findings that may be caused by uncontrolled hypertension. We're also going to review some of the medication choices we have and their considerations, and then a basic general approach to resistant hypertension. A lot of these are recommendations that are, through the American Cardiac or College of Cardiology. They're also found on UpToDate, other things like that, but it kind of gives you an algorithmic approach to try to treat these patients and where to start and other options that you may have. First thing I'd like to say, it's an internal medicine lecture. We don't really address any pediatrics. A lot of times pediatrics with hypertension often are due to some form of secondary hypertension. There's a known cause for it. That's a whole different ballgame. I just want to kind of go over more of the primary care type issues or findings that we might have at this point. I also don't cover things like preeclampsia or pregnancy type issues. That would be a separate lecture for those kind of things. We all know the prevalence of hypertension. It's all over. A lot of times it's linked with obesity, and you can kind of see it on these charts or graphics, especially through the CDC. And you can kind of a lot of times see where those resistance rates are, as well as where some of the other chronic conditions may lie. We all know that the Southeast definitely has a higher rate of obesity, diabetes, and other issues, which often commonly linked with hypertension as a cause for that. So those kind of issues down in those areas are way more common than other areas. These are 18 and older. This is a little bit older of a prevalence map, 2018 to 2020. However, I haven't found anything as recent as this for a map, but I imagine that a lot of the standards are the same at this point. Risk factors associated with hypertension, predictors for difficult control are often seen. So, these things might not be stand out within our assessment right off the bat, but these things are difficult or are predictors that may kind of cue us in, hey, this person might have a little bit harder, or we might have a little bit harder of a time controlling this person's blood pressure. Typically, anybody that has a higher systolic pressure versus a diastolic pressure, those patients sometimes will have more difficult time controlling their blood pressure. So you may give them a medication and their systolic pressure does not come down as much as you would like it to do, where it's a little bit easier sometimes with a diastolic pressure. Patients that have an underlying left ventricular hypertrophy, so they have that thicker muscle on the left side of the heart, are often more difficult to control. Patients of older age, now these patients may be a little bit more resistant because they have stiffer arteries. They may have other underlying conditions such as kidney disease or other issues. This can cause also a difficulty in controlling blood pressure. Obesity, we all know that that's a common risk factor. These patients have much larger vasculature, especially down into the capillaries, just to get all that extra weight. So those patients are often harder to control. Chronic kidney disease, they don't filter, they don't do as well. And then patients with diabetes. All of these things, will add to difficulty in controlling patients' blood pressure. Now, if you add them all together, so a patient that has diabetes, chronic kidney disease, is older, and has obesity, this person is going to be much harder to manage than, say, somebody in their 30s who just has high blood pressure, and you're not, you're just treating them from that point. So more combinations, more difficulty. As you add these things up, it's probably going to be harder, and they're going to need more than just a one medication regimen a lot of times. Now, there's different stages of hypertension. We all have heard this before. Stage 1 typically is that systolic pressure between 130 and 139 with a diastolic of 80 to 89. So it's a little bit elevated. Typically now they want pressures lower than 120 systolic, which is common. That's a little bit different than what it has been in the past, but now systolic pressures elevated between the 130 and 139. That's typically noted as stage 1. Now, as you increase, you're more prompted to develop kidney disease, heart disease, and all those other things. So stage 1 is kind of like an initial for that development. So as you get higher, greater than 140, greater than 90, that's typically stage 2 at that point. Anything over 180 systolic or 120 diastolic, that's you're kind of in the hypertensive crisis. And that's where you kind of got to figure out, hey, is this hypertensive urgency or is this a hypertensive emergency? Now, in hypertensive emergency, a lot of times those require chronic stat laboratory or stat imaging at that point, which is often done in the emergency department. But that's where you kind of need these diagnostics to kind of determine those two. And we'll go over that here in just a second. Like I was saying, hypertensive emergency versus hypertensive urgency. So an urgency is a blood pressure 180 over 110 or higher on those, but they have no evidence of organ damage. So, you get lab work done, you don't have an elevations in troponin, you don't have abnormal renal functions, you get a chest x-ray, you don't see pulmonary edema, they don't have any EKG changes, they just have straight elevations in their blood pressure 180 over 110. That's typically an urgency. So those patients are at higher risk for developing organ damage, but they're not quite there yet. So those patients need to be addressed, but it's not an emergent situation. Versus hypertensive emergency is the same blood pressure, but like we were saying, there is evidence of organ damage. So the patient has pulmonary edema, cardiac ischemia, neurologic deficits, renal failure, other things you might see on a lab work. Those patients really need to be addressed quickly because that organ damage can be further exacerbated by the blood pressure remaining high. So like I was saying earlier, those typically are within the emergency department, but you may see a patient that has elevated blood pressures, you put them on something, you get some labs back in a few days, and you start noticing, they might have elevations in their creatinine or other issues, because that could have been signs of an organ damage secondary to elevations in their blood pressure. So when you're considering hypertensive concerns, you always got to consider differentials for those situations. So is there a potential secondary cause for these issues? So is it a primary hypertensive or is it a secondary cause? So primary causes typically there's no specific cause. You don't see it. It's just something like, like we were saying earlier, a 30-year-old person comes in and says, or they didn't have a complaint. They just came in for their random check or a physical, and you notice that their blood pressure is 150 over 90. You take a bunch of serial blood pressures, you get them all back, you do some lab work, you do some EKGs, you check other things, and you don't find anything specific that's telling you this is exactly why this person has elevated blood pressure. There's no diagnosis for it. That's typically what they refer to as primary or essential hypertension. It's the most common. It's often influenced by various things like we wrote on there, they're older, stress can do it, salt intake, dietary, excessive, alcohol, obesity, sedentary lifestyles, those kind of things. So those kind of things need to be addressed, and typically, or hopefully, that will bring down their blood pressure at that point. Now, secondary causes, there's a cause that's known. You have, and sometimes that can be due to, you have a primary essential hypertension. You go ahead and treat it, it's not coming down. You add something, you go ahead and treat it, and it's not coming down. And then you start thinking of differentials at that point. What else might be causing this? So you do a little bit more. Lab work comes in, you find kidney disease. Now, whether or not that's due to the hypertension or the hypertension is due to that, that's different. Other things you might consider are things like adrenal diseases, parahyperthyroidism, thyroid disorders, sleep apneas, pheochromocytoma, other things like that are actual causes inside the body that you find that will cause a blood pressure to go up. Those are referred to as secondary causes. So that pheochromocytoma, the patient gets a headache, they get intermittent palpitations, they can't rest very well, their blood pressure remains elevated. You do some urine studies on them, you find, and some imaging of their adrenal glands. Pheochromocytoma is noted. They go to surgery. They take out the pheo. Typically, their blood pressure will drop back down, and that's a secondary cause. So primary cause, no specific cause. Secondary cause, their cause is known or it's found in some way. Then there's something called pseudo-resistant, and this is actually very common. So a lot of people will be on multiple regimens of a blood pressure medication, but their blood pressure is just not coming down. And so they get kind of thrown into this, you have resistant hypertension, which not always is it the case that you have that resistant hypertension. So you may have something called pseudo-resistant. And this takes a little bit of more deep dive into the patient and asking them questions, and otherwise maybe finding another cause for this. So is the patient taking their blood pressure medications? Do they forget? Are they taking them regularly? How are they taking the measurement? Are they using those little wristband things? Typically those are not very accurate. Or are they resting for 15 minutes before they take it? Or are they up and about and, I'm cleaning the house and now I'm going to take it and it's elevated? Those kind of things are important. Inadequate dosing, the medications aren't dosed appropriately. The combinations are not exactly correct for a person's age, ethnicity, male, female. All those kind of things matter as far as choosing your antihypertensive. Do they drink a ton of alcohol? How's their diet? Tons of salt, sleep apnea. Are they using tons of NSAIDs? So a person that just, has chronic pain and is just taking handfuls of ibuprofen all the time, that's going to cause renal issues, but it's also going to elevate their blood pressure. The other one is when they come in, they see you, their blood pressure just goes up anyway, especially if they're coming in about their blood pressure, they're going to be elevated. So you got to make sure all of those readings are accurate and it's well laid out in different times of day, and these kind of things are addressed as far as potential causes. Because these can be an indication of what they call pseudo-resistance. So it's not exactly resistant. There's just something else going on or not going on that's causing their blood pressure to be high. So these things should be addressed, obviously, every time the patient comes in, especially if their blood pressure is high. Are you taking that right? Are you still taking all those NSAIDs? How are you doing on your salt intake? Or have you cut back on your alcohol? All those kind of things, because they can cause it. So now getting into resistant hypertension. So resistant hypertension definition is a blood pressure that's greater than 140 with the use of 3 optimal hypertensions, including a diuretic. So you might have, ACE inhibitor, Norvasc, and, Toprol, or like a hydrochlorothiazide or something in there, and it's just not coming down. This may be caused by maybe a secondary hypertension. So when you get that combination going and it's not coming down, you really got to think of those differentials. Like, what else might be causing this problem here? Should I look further that this person may have a pheochromocytoma? Should I look this person has obstructed sleep apnea? Those kind of differentials, especially every time you add something onto them, you should really think, is this, what else might be causing this problem? These patients are higher risk for end organ damage. So end organ damage, because their blood pressure is higher than normal, but also you're putting medications into them. So medications are something that your body does not make. So each one has its own adverse effect. So, and we'll kind of go over some of those things. But so, for example, a person has a blood pressure 140, or let's go higher than that. Say 150 over 92 or something like that. You have them on multiple regimens of medications. It's not coming down. You've added an ACE inhibitor onto them. Now you redraw their lab work. What their creatinine was normal now is not normal since the ACE inhibitor was added. Secondary cause could be renal artery stenosis. So that's something to think about. So I just added this medication. Now I have this outcome. So they're higher risk for end organ damage because of the medications at that point. And also additionally the high blood pressure. So it's something to definitely consider about that. Kind of what we just kind of addressed a little bit, but these are true resistant causes a lot of the times, but they're also secondary causes as well. So underlying, they may have, hyperaldosteronism, renal artery stenosis, worsening kidneys, hyperthyroidism, pheochromocytoma, aortic narrowing, Cushing syndrome. These are more rare, but they definitely should be on your radar. They take good physical exam, good history taking, and often diagnostics to really rein this in to try to figure out why this person is having such a high blood pressure at that point. And like I was saying, physical exam is important with that. So when you do your physical exam, you really got to do a physical exam about these patients. So they come in, they say their blood pressure is still high, and I know a lot of times in primary care you only have 10 or 15 minutes. It's really hard, but it really needs to be focused. So you're looking for the extent of their that may be causing their problem, but you're also looking at the complications that may be caused by the high blood pressure. So when you're looking in their eyes, you're looking for retinopathy. Do you have murmurs now? Are they higher risk for aneurysm because their blood pressure is so high? You're looking for all these things on physical exam. Palpitant masses in their belly. Are they a smoker? They're higher risk now because they have high blood pressure. You're also looking for potential causes for that secondary hypertension. Bruits. So I personally have never heard an abdominal bruit really before. I've heard femoral bruits, but abdominal bruits can be an indication of some form of sclerosis, arteriosclerosis going on, especially in the renal arteries. So that's one thing to know. Varied extremity pressures. You might have aortic problems, maybe raising the blood pressure, all these kind of things. So the physical exam is a very important aspect of hypertensive examination, because this can kind of cue you in, hey, person's got high blood pressure, maybe this is the cause. I need to look at that more as well. And again, diagnostics roll into that as well. So you're doing your exam. I'm not exactly finding anything that kind of sets me as in a path that may be causing this. So maybe now that's where diagnostics comes in to try to figure out maybe other causes for this. And now, of course, those things would be like, EKG, lab work, urinalysis, echoes, all those kind of other things. So again, diagnostics. So the first thing to go through with EKG, and a lot of times EKG changes are a cause of the high blood pressure. So we all have heard of left ventricular hypertrophy, or LVH. That pressure is higher, so that heart beats harder, and that left ventricle, which is what's responsible for pushing all of that blood out into the body, has to pump harder against higher pressures. And what that does, it's like going to the gym. So you're doing the weightlifting, your bicep is getting bigger, so is that left ventricle. And as that left ventricle gets bigger, the volume within it to pump out gets smaller. So that's a sign of high blood pressure over time. That LVH is a side effect sometimes of high blood pressure. And like we said earlier, person has high blood pressure, you do that EKG or that echocardiogram and you see they have left ventricular hypertrophy, that could clue you in this patient may be a more difficult case to control. Other things like ST segment changes. Does the person get winded when they walk? Do you see signs of ischemia? So they may have underlying coronary artery disease. This kind of thing would also probably have arteriosclerosis associated with it, which can also cause higher blood pressures. Prolonged QT syndromes. And then this is kind of just giving you a little indication of what often happens with longer hypertensive episodes is you kind of get this P and T wave changes that can look a little bit different than a normal EKG. So these kind of changes that you see on there can kind of clue you into the heart's responsiveness also, or other things that I need to look at potentially as a cause for the hypertension. So here's an example, and I don't know if my cursor will show on there. I'm not sure. I think it will. This shows you basically the hypertrophy, ventricular hypertrophy, right in here. And I don't think it's working. But, oh, there we go. Right in here. And there is criteria for this, but typically what you're looking for is that you're going to get especially in lead, V2, V3, the precordial leads, is this big downward deflection. And typically they will overlap each other. And this is a huge impulse going through a thickened layer of the muscle. And this is indicative of a left ventricular hypertrophy. So that's a thick muscle. And then what can happen over time as that muscle gets thick and say it needs more demand is you can start seeing things like a ventricular strain. So it almost looks like ischemia over here. So that's the body trying to compensate in some way for those higher pressures. And I have listed in their LVH criteria. But usually what you're looking at is you're looking at V2 and you're looking at V5 and you're measuring those two, and typically it's greater than 35. I think they used to refer to that as Scott's criteria, but I'm not sure anymore. But just as a general note is if you start seeing these overlap of these QRS complexes, especially right in the middle anterior leads here, that's indicative of a left ventricular hypertrophy. Here you go. Here's the true criteria, but again, you can see that right through here and then here. But if you wanted to do it, you would measure these boxes here and then measure these boxes here, and they would add up to a certain amount, 35, and then that would give you the indication. But overall, if you see overlap like that, that's pretty indicative of that problem. Here's another one. This is just something, say a person walked into your office and they're here for their check and they said they've been way more winded than normal, especially when they walk, and you just get an EKG right after they walk over there. And you notice on here that they're ischemic. Here, and here, and here. You can see that. That can be a sign of underlying CAD. Can be hard from the heart pumping so hard because of the pressures or because they have coronary artery disease, which can cause also increases in blood pressures from that point. This is a lot of lateral leads here, and this here is the anterior leads up in this area too. So this here would be the circumflux artery, and then right through here would be the LAD or the branch of the septum right here, but not so much up in that area. And then again, this is something you might just see as a random EKG that you may do, but you also notice that all of the lateral leads here, so the circumflux lead artery, you have T-wave inversions there. So a person with hypertension, not knowing a cardiac history before, getting a good history is important. This person might want to go for a stress test or some other way. And also this would cue you into exactly which medications might be better for this patient versus others. So, if they have no history of, bronchospasms or other issues like this, something like a toprol or a beta blocker would be better for this because that's more for patients with coronary artery disease and other things. So the EKG will show you changes typically because the person has high blood pressure, but it also gives you an indication that maybe their blood pressure is a little bit higher because they have underlying coronary artery disease or arteriosclerosis or some other issue, but they kind of go hand in hand, and it's a good diagnostic tool. So next, you're doing your physical exam and you hear that murmur, or the patient says, their blood pressure has been so high, but I've also noticed that I'm swelling up down in my feet, or you hear some rowels bilaterally, or the patient can't walk up and down the stairs like they used to. So the echocardiogram is really going to give you a good cue into how the heart is performing. So as that heart pumps and you get the LAD, over time, those pressures staying so high, it's going to affect the stroke volume and the heart pumping capacity. So over that's when the echocardiogram comes in. And also, you're also looking for valvular issues. So a person that may have like a mitral valve issue or some other issue may constitute and cause a reason why a person has higher pressures as well. And just a quick definition. So systolic failure, systolic or systole is basically when the heart pumps out. So it's squeezing out. Diastolic is when it relaxes back down. So the pressure when it pushes it out, so you're squeezing the bag, that is the pressure taken, that's a systolic. When you let it out, it's the pressure left in the bag, that's diastolic. So if you get systolic failure, that's telling you that the heart cannot pump. So it's not pushing out as much pressure as it should. And say the pressure outside of it is much higher than normal. You can see the heart pushing for so hard for so long, it's going to start to basically thicken, but it's also going to start to weaken over time. And you can develop systolic failure. And hypertension is a very common cause of that. So the ejection fraction, so the Simpson EF or whatever you're going to get is typically reduced. So less than 60%, some places say 50%, but it's going to start to fall. Over time, it gets so low. I've seen patients with EFs of 9%. They're on so many medications to keep it going. They have a life vest, all those kind of other things, but it's very important to control those pressures at that point. Diastolic failure is the other one. So the pump can't, or the heart can't relax. So the pressure is too high after it opens. So it pumps out just enough that it's supposed to. So you're getting the normal EFs, but when it relaxes, the pressure left inside the bag or the heart is way too high. So that's a diastolic failure. And those ejection fractions are preserved. Acute diastolic failure, especially when I used to work hospital medicine, way harder to treat than systolic failure. You really got to look at the reasons for it. Typically, the diuretics don't work as well, all those kind of other things. So that's one thing to note. So systolic failure, heart can't pump, EF is down. Systolic failure or diastolic failure, heart can't relax, but the ejection fraction is preserved. It looks good. It's still fine. It's usually above 60% or so, 50% in some places. Let me go back. If you're looking up in here, so this mediastinum here, if that's way wider than what it's supposed to be, that may be an indication that the patient may have an underlying thoracic aneurysm. So that can be caused by elevations in the high blood pressure, or maybe a secondary cause as well. So that puts the person at higher risk, but you're also looking at that as a potential underlying cause, or not cause, issue that may come from a person having such high blood pressure for some time. Oftentimes those patients they smoke a lot, they're very tall and lanky, they may have an underlying connective tissue disease like Marfan's disease or something like that, but that chest x-ray gives you a good indication. So if the heart is large, they may have heart failure. If the aortic size is large, they may have an underlying thoracic aneurysm. The other one is if they have fluid within the lungs. So that's an indication of that left-sided heart failure. So you start getting the fluid, and what they say is it's kind of like a bat wing appearance. So it starts coming from the vascular, spreading out. That's fluid backing up, and that can be an indication of congestive heart failure, and also linked with hypertension as well. And effusion's kind of the same thing. There's different types of effusion, but it can also be caused by heart failure as well. The heart is really big right here. So that's way bigger than a third of the heart. So that's an indication of potential heart failure, cardiomegaly. Next one, you can see the fluid within the lungs here. The heart's a little bit big, but you can definitely see the fluids here. Heart failure, especially with hypertension. These kind of clue you into what medications could get. So if this person's got heart failure, typically the ones we look for are the ACE inhibitors, if they have CAD also, the toprals or the beta blockers, and then diuretics and such. This one's got a large mediastinum, which could be an indication right there of a potential aneurysm underneath with an uncontrolled blood pressure. So the chest x-ray can really cue you in as potential causes of the blood pressure or secondary effects from having such a high blood pressure in some way. And this is always something good to get on those chronic hypertension patients. Then there's laboratory studies. Some of these are more in the emergent setting, but in the general setting, CBC, CMP, A1C, BNP, troponin if you're in the ER, if the patient's having cardiac issues or suspected. UA, you're looking for protein. UTOX, my area, because it's very prevalent for methamphetamines up in this area, which can be a cause of elevations in their blood pressure. It's really important to get something like that. Cocaine will do it. Those also cause chest pain, which is why a good troponin is also good with that. And you also might think of some other secondary workup labs for pheochromocytoma, things like Cushing's, the aldosterone issues, or Addison's disease, all those kinds of other things. So those endocrine type issues, those can also be used as a secondary workup to try to figure out why the patient's blood pressure remains so high. Things you're looking for, like within the CBC, is typically you can get anemia secondary to a chronic kidney disease. So a person has anemia because their kidneys aren't working so well. You're going to see that as well. So they're anemic, but also their creatinine, BUN, all those things will be off a little bit. So they're also not moving oxygen as well because they're anemic in some way. CMP, liver functions can be off, portal hypertension, all those, alcoholism. They're going to have elevated bilirubins. The AST is typically higher than the ALT in a person that drinks too much. The way I always remember it, and I think a lot of people learn the same way, AST is Scotch and tonic, so that's typically going to be higher than ALT, and that's an indication that the person is drinking a little bit too much. You can get things like alcohol levels, but that's usually acute, but you can also get something like a GGT to try to figure out where their alcohol consumption has been within a certain amount of time. BNP, that's going to show you the fluid overload. If a person's got, depending on the source that you get, if their BNP is higher than 400 or 500, that's usually an indication that they're slightly fluid overloaded. It could be an indication that they're having underlying heart failure in some way. And then we talked about the UTOX, because that can be a cause of elevations in their blood pressure as well. Now on to the medications. So a big thing with this is to always consider a patient's ethnicity as well as their history. So, it's time and time again, I often see patients, say, of African American descent that don't have diabetes, who are initially placed on something like lisinopril. So those kind of medications, they don't typically work as well in a patient of African American descent versus other populations. And I think sometimes that's just something people just don't know. So those kind of choices, just using that as an example, are things to really consider. So maybe that person would do better with something like Norvasc or something like hydrochlorothiazide as their initial type medications. So ethnicity, but then you also got to think on top of that. So this person, African American, but they also have a history of CAD. So obviously I'm not going to put them on an ACE inhibitor because that's not the best thing, because they don't have heart failure, just have CAD. So there's maybe something like Toprol would be a better medication for this. So there's a lot of factors to go through, and it shouldn't just be a reflex like, oh, I always just start everybody on lisinopril when they walk in the door if they have high blood pressure. It's a very focused exam, and there should be some considerations. And that's that optimum utilization of medications that we talked about that can lead to pseudo-resistance. I had a patient just recently who was African American who they couldn't get his blood pressure down, and he came in and he was on 100 milligrams of losartan. And again, it kind of falls into that same category. We changed it around. We put him on Norvasc, and I think we got it up to 10 milligrams, and then added, I think, a little bit of a diuretic, and now he's down 118 and he's doing much better. So it's very considerate to consider those kind of things. So your initial approach, you have all kinds of choices, right? My experience is I do work a little primary care sometimes, and I do deal with primary care type issues. I worked hospital medicine and I worked in emergency department as well. So it kind of varies. So your selection of medications all is dependent, like we said earlier, on the venue that you're working, but also on those things we talked about before. They're very patient specific. So you have lots of choices. This is just a little bit. There are tons of medications out there. I've always been of the mind of each category to remember, 2 to 3 as your initial medications, and what they are specifically used for and what they would most benefit from based on their history. And those kind of things kind of lead me down in the path. And I also remember, which ones are good for or for renal problems, what some of the contraindications and what some of the adverse effects. Because honestly, it's really much, there's so many medications out there, it's kind of impossible to remember them all. We all went through school when they threw everything at you, but once you get out here, you got to kind of remember, these basic ones and be try and true to those. You should know about the other ones, but you should be very familiar with a very select amount of them. So calcium channel blockers, I'm a big fan of them, especially because they work very well. They do have side effects. Calcium channel blockers, you can get away with, is a good start. You don't necessarily have to focus so much on the patient's ethnicity because they do work very well among all of them. Now, there's certain things that you got to watch out for with calcium channel blockers, but one thing is it's not so much the renal problems. So they do pretty well with patients with renal type issues. Now, there's 2 different types, and I have to admit straight up, I have phonics dyslexia, so I have a hard time pronouncing some words sometimes. I often tell patients that so I don't sound so off the wall when I say it. But the dihydropyridines, I hope I'm pronouncing that right, and then the nons. So there's 2 different types. So this class is typically with the vasodilators. So those are the more common ones, like Norvasc. That's the one you see quite a bit, the amlodipines. Those do very well. They usually cause some form of vasodilation. So they work well with those kind of, like I said, they work very well to try to bring blood pressure down. By blocking calcium channel blockers or blocking calcium channels, they can cause this issue or this dilation within the vessels. Good for chronic care or management or chronic management. They're good for patients with subarachnoid hemorrhage. You can see Cardine given a lot of times within the emergency department. They're good with patients with angina, especially small angina, and hypertensive crisis. They do pretty well. And they're very effective for African American populations. And we'll go over some of the side effects and contraindications as well. One thing to say about this class is that they're not so well or recommended with a high level of heart failure. The nons, they work kind of like beta blockers, so they'll decrease the heart rate. They slow the conduction. Examples of those are cardizem, so diltiazem, verapamil. You don't see verapamil used too much outside of the hospital. But they're good for hypertension, but they're also especially good for patients that have maybe underlying cardiac arrhythmias like atrial fibrillation or supraventricular tachycardia. Supraventricular tachycardia may not be the first go, but if a person has come in asthma at the same time and you want to avoid those beta blockers, something like diltiazem could be a good alternative and choice. But they do manage not as effectively maybe as the other class, but they do effectively work on hypertension as well, kind of similar to decreasing the heart rate, which decreases the force and decreases the blood pressure. Side effects, the dihydropyridines, they can cause lightheadedness, but this is something you can see in a lot of the medications, especially if it lowers the blood pressure too fast. They can get flushing. They can get peripheral edema. That's one of the most common side effects I see a lot of the times, besides things like constipation you often see with calcium channel blockers. But patient comes in for the recheck, you just put them on a calcium channel blocker. Now you're looking and, they have a little bit of edema down there. It's probably secondary to the medication. Maybe I need to move off and try something else at that point. The nons, constipation, they can cause bradycardia. Like I said, it slows the conduction down. It also decreases cardiac output. these kind of medications or any of the classes of these, you got to be really careful with heart failure, especially if it has the reduced ejection fraction. So, if you're thinking about they got blood pressure issues, they have atrial fibrillation, but they also have heart failure, and you're thinking about different types, maybe the calcium channel blocker isn't the best. You can think of things like carvedilol, or you can think of things like amiodarone at that point. Don't work quite as, or amiodarone is not very good with blood pressure, but it's something that you can use to control heart rate at that point. Second and third degree heart blocks, same with beta blockers. You don't want to slow them down anymore, or sick sinus syndrome, or just bradycardic in general. Those kind of things you want to avoid. They can be used in combination with other hypertensives, which is great. Like I said, if effective in main African American populations, fairly safe with renal disease, which is good. It's a good alternative to like patients that can't tolerate a thiazide diuretic, or they can't take that. Say they got a history of gout or something, or they have a long history of low potassium or something like that. It's a good alternative. But things like, especially the dihydropyridines and things like that, shouldn't be the initial one, especially with heart failure, because they can exacerbate that, causing peripheral edema, buildup of fluid, other things like that. And the nons are completely contraindicated in heart failure, especially with reduced EF. Beta blockers, they say they're not the first line unless they have a history of heart failure or MI. You often see that a lot. A person will just be placed on Toprol and then asked to check in. They do lower your blood pressure. They do lower your heart rate as well. These medications can often be used well with patients with anxiety, though. That's one thing to consider. A beta blocker will lower their heart rate and kind of calm them down at the same time. So that's one thing to consider. But patients that do have some underlying cardiovascular disease, they do work quite well by reducing heart rate and decreasing pressure. They have been noticed to, I was looking at some studies, to have increased in rates of stroke over 65, so that's something to consider. And also with patients with diabetes, it can influence their blood sugars. So that's one thing to note. We were always taught that it would cause hypoglycemia, but I also read some studies that it can cause hyperglycemia as well. So just one thing to consider when giving out these medications. Then there's beta blockers. Like we said, there's two different classes. There's beta 1 and there's beta 2, and then there's also a separate one that can be influenced, which is an alpha receptor. But beta 1 medications, which they typically refer to as cardio-specific, they affect the heart rate. So one heart, beta 1 heart rate. Beta 2, 2 lungs, can affect the lungs as well. There's beta 1 specific, and there's beta 1 or 2 non-specific medications. So, when a person has asthma, you probably want to avoid more of the beta 2 or beta blockers that have beta 2 effects, because it can cause bronchospasm, and just look towards the others that just have more of a beta 1 effect. And we'll go over those as well. But the good thing always remember is a beta 1 cardioselective, because there's one heart. Beta 2, which can influence the lung, because there's 2 lungs. That's one thing to remember with it. And here's what we were talking about. So beta 1, they work on the epinephrine hormones action. So those kind of things cause vasoconstriction. It kind of counteracts that. It opens up the arteries, and then you can have lower blood pressures. These are found in the heart. They're found in the renal tissues. They decrease heart rate and contraction force. So beta 1, common ones you'll see is atenolol, especially on the outside within the primary care. And then the esmolol, that's not so much seen. That's more like emergency department. A lot of times what you'll see is patients with like acute aneurysms and other stuff like that. Those kind of patients will be placed on that to lower their heart rates. And then there's metoprolol, Toprol, that's another one. They're more beta 1 specific, so they target the heart more. So the non-selective, where the beta 1 and 2, or they even have alpha effects of it as well, those have that beta 2 in it, which can be found in a little bit of airway tissue. So those can have increased chances of having some form of bronchospasm or other things going on. So those kind of want to typically be avoided in a patients that have a lot of underlying asthmatic or other issues. So carvedilol, labetalol, propranolol, those kind of ones, maybe not such the best choices for those kind of or those kind of patients. Labetalol is a good one for patients that have resistance, and we'll go over that. Carvedilol is a good medication for patients that have chronic AFib and heart failure at the same time. Propranolol is a good one for patients that have anxiety as well, or let's say they got chronic migraines or something like that. That's a good one to choose to kind of target all those things at once. Because the less medications you take, the better. Some of the adverse effects, they obviously can cause bradycardia. They can cause hypotension. That's pretty obvious. They can increase fatigue in patients and depression. I have a personal experience with that. My daughter had SVT before she had her ablation, and they had her on a beta blocker. And once she started that a week later, we could really tell right off the bat that she was definitely more fatigued, but she was also more depressed while taking that medication. So it really does have an effect. And like we talked about, it can alter blood glucose. They can cause bronchospasm in asthmatics and sexual dysfunction in some adults as well. Contraindications, bronchial disease should be on there, especially with the beta 2 non-selective ones. Beta 1s, there's less risk, but it should be something you think about. Patients with Raynaud's, usually those are better with calcium channel blockers. Patients with bradycardia or heart block, you want to avoid those kind of medications because those patients usually have a slower heart rate anyway, and you're slowing it down even more. That's going to cause adverse effects for the patients. So moving on to ACE inhibitors. ACE inhibitors are very common. You see them all the time. They work on inhibiting the ACE within the whole renin system down into the kidneys. They work really well on diabetics. They're kidney protective. They work very well with heart failure patients. They can be diagnostics sometimes to try to figure out what's maybe causing the person's high blood pressure. So like I was saying earlier, you might have a person that has a little bump elevation in their creatinine. So you want to put them on lisinopril, bring down their pressure. You want to protect their kidneys a little bit. You put them on there. A month later, say you do another BMP to check out their kidney function, and you notice that their creatinine is bumped up even higher. That could be an indication that there's underlying renal artery stenosis, and maybe that should be imaged in some way. Typical adverse effects, and we've all seen this, dry cough that happens all the time. One thing to always consider, though, is hyperkalemia. So these patients will hold on to potassium. So if you put them on something like lisinopril, and then somebody puts them on spironolactone, which is a potassium-sparing diuretic, you may see very high levels of potassium, which can lead to cardiac arrhythmias, can lead to cardiac issues, other renal issues, those kind of things. So really watch that. Several times in my career, I've actually seen angioedema from this as well, and it's very prominent. You really typically see it right around the lips. The lips will just swell up, and that's one thing to really watch out for it. We talked about their worsening renal function with renal artery stenosis, and I've also read some studies that show that when a person's renal function is quite bad, it's actually not a good idea to use these type of medications at a certain point. But a lot of times that's specialty consultation at that point. So, and then you always use them with caution with renal or aortic stenosis and other things. So you put them on an ACE inhibitor and they get this coughing fit. They can't stop coughing. One thing you can substitute them for are the ARBs, so the angiotensin II receptor blockers, losartans, valsartans, all those other ones. I have noticed that sometimes those are a little bit more expensive, usually, but they can be used as a substitute. They're very well tolerated. They have lower rates of cough, lower rates of angioedema. You do have to lower the doses with hepatic impairment with that one, but it also is kidney protective, and it's something to consider with that. Not necessarily recommended that you use it with another ACE inhibitor. those two together are not such a great idea. They also have the hyperkalemia risks because it's losartan potassium, so that can cause elevations in hyperkalemia. So your next choice of medications should really be, you should be cognizant of the things that may really increase their potassium as well. And it's not uncommon to do routine lab work and have a patient on an ACE inhibitor or an ARB, and you notice, say, hey, their potassium now is 5.1. That very well is likely probably due to the medication that you're giving them. The main thing is you're looking for either alternatives or EKG changes or other things at that point. So moving on to the diuretics, there's several types. There's thiazide diuretics, and there's loop diuretics, and there's other diuretics. But the thiazide diuretics, we all know hydrochlorothiazide. We see that quite often. Chlorothiazide, that's another one you'll see. It's a little bit more potent, longer acting. These are not the best patients or best medications to use with patients with gout because it can cause flares. It is a diuretic, so it can cause dehydration. So they do lose electrolytes with this. Best dosed in the morning, take it at night. Sometimes the patient's up urinating all night because they do pee quite a bit with it. You know, you can dose it at 12.5, 25. You don't usually see higher doses at, or not necessarily recommended at 50, but you can see them getting up to that high at that point. And there are good medications for African American populations. They do tolerate them quite well. And then the other ones, chronic ones, we know patients with heart failure, they have evidence of fluid overload. Lasix is something that will help get that third spacing fluid off the body and help them urinate that out, get the fluid down. Fluid taking off, fluid means there's less volume inside the pipes, so that means the pressures will drop. You often give those with some form of potassium supplement because you will lose potassium in that way. So a patient might have cramping. You might notice that their potassium ends up getting lower. You worry about EKG changes, so you're going to watch for things like that. Now, if the patient can't tolerate that or is not holding on to potassium as well, things like aldactone, which is a potassium-sparing diuretic, can be a good alternative for that, for something for them to use. It still works like a diuretic, but it kind of holds on to that potassium, which is a good thing. They're typically less effective in younger white populations. So hydrochlorothiazide, a younger white population, or any younger population, you really got to worry about a secondary cause. So a person in their 20s shouldn't have high blood pressure unless they're obese and they have other confounding factors. But there might be a secondary cause in there somewhere, so you should really think about that. Patients that are overweight, poor diet, higher risk for gout, necessarily not a good one to choose. Always worry about electrolyte losses. But like I was saying, diuretics are effective in African American populations. So combination therapy with all of these things is something to always think about. Like we were saying earlier, should be based on your ethnicity and their history. So, racial backgrounds, and also should be their chronic history, diabetes, chronic kidney disease, heart disease, all those kind of other things. Diagnostics can be used to find the extent of the damage or something that might be being caused because the patient's blood pressure has been so high, left ventricular hypertrophy, kidney disease, other things, but they can also be used to try to figure out secondary causes for this. So imaging of the kidneys and adrenals, you might find a FEO. Diagnostics to find the FEO, you might have the urine studies for that. They all help with that. And physical exam is very important too. So some examples when the combination therapy like we're talking about is based on their history and other factors. So a patient with diabetes and CAD, ACE inhibitor would protect the kidneys. Beta blocker would help with the CAD, with the heart. You would have to watch the diabetic a little bit, but it may help bring down their blood pressure or blood sugars as well a little bit. Being understanding that it can cause hypoglycemia and other things. History with COPD and MI, you might think of that calcium channel blocker because if you give them the beta blocker, especially the beta, something that's non-selective, you might exacerbate or cause the bronchospasm there. So something maybe like a calcium channel, like diltiazem or something, might be a good one. If they have Raynaud's syndrome or something, that would be also a good one to choose. Atrial fibrillation and heart failure, you might think of something like carvedilol, adding an ACE inhibitor to it. If they have fluid overload, then you're going to add a diuretic to it. If they're having problems holding on to their potassium, spironolactone would work. However, you've got to think about that ACE inhibitor because that ACE inhibitor is also going to raise their potassium levels, so it's something to think about. Angina, CKD, something like a isosorbide that kind of works as a long-acting vasodilator is something to think about, especially with patients with angina and kidney disease, would be the ARB that would kind of help with that as well. You don't see the isosorbide so often, but that can very much help, especially if a person is taking nitroglycerin tablets or something that can help lower their blood pressure because it's longer acting, but also help with their symptoms as well. Some good medications for short-term use that you can use and you should know about are clonidine and hydralazine. These are good ones. I used these quite a bit when I was working hospital medicine. Clonidine comes in a pill or a patch, which is kind of nice. The pill is usually dosed, it's very low, 0.1, 0.2, 0.3, usually twice a day or that you can dose it. The patch is usually kept on for about a week. You can peel the patch off. It may have some lingering effects. The pills, sometimes you can just taper it down from that point to avoid what they call reflex hypertension. So these are centrally acting. Like I said, there's a pill or a patch. They can cause sedation. So, the Beers list kind of stuff for the elderly, especially a patient that gets placed on clonidine and they start, nodding off or they start having lower energy, that's something to really watch for. You want to avoid abrupt discontinuation with these patients, though. You can get something called rebound or reflex hypertension with these. So anytime a patient is placed on clonidine, it really should be tapered down over a period of time. That's one of the disadvantages with it, but it's something to really be aware of. They're good with patients with history of opiate abuse because it can curb cravings as well. It works really well with that. Some people use it for mental health problems as well, but it's one thing to consider. But there are some renal adjustments that you need to make if you do choose this medication. Hydralazine is a potent vasodilator. It causes a huge dilation. It's not very long acting, which is one of the things that's really nice. But it can cause headache. One of the main things you'll see is that it's not so good with a patient who's tachycardic. So, if you're working hospital medicine, you're giving fluids and the person's pressure is really high, say if they're, septic or something like that. And it's not a very good choice because if they're tachycardic, it can cause even worsening issues at that point. Dizziness, it can cause, obviously, if it causes vasodilation. You should use it very cautious with patients who have suspected CAD because that big burst of vasodilation can cause some significant cardiac issues. You don't want to use it with patients with angina. There's other alternatives for that. But it can be used with renal patients. Unless it's significantly advanced, then you want to avoid it. So those are some good alternatives. I use those quite often for my patients that, I just want to get under control before I can get them managed on a chronic medication at some point. But these typically are not used like initially. They're used for patients that are on something and then their blood pressure goes high and they have consecutive measurements that stay high and it needs to come down at some point. So the approach to resistant hypertension as a kind of like an algorithmic approach, I just want to kind of go over some options that you may have and some way to approach it. So you should always start by thinking of a cause, so a differential. What might be causing this person? So I started him on this med, then I added this med, and it's still high. What else might be causing it? I don't see anything right off the bat. I add another med. You're going to think about another cause. Maybe, did I look at everything? What's another reason? Is this pseudo-resistance? All those kind of things. You're thinking about causes because things like underlying secondary causes like FeO or aldosterone problems or other things, you can keep adding medications, but it's going to stay high. So you got to think about other issues for this. So always, whenever you make a change, reevaluate. One, make sure that all the information you're getting is correct and all the patient has been doing what they're supposed to be doing and taking it the appropriate way and their diets and all kinds of other things, but also that you're not missing some other secondary cause in there. So some considerations, like we were just talking about, always inquire about compliance if you've been taking your medicine recently. There's a lot of information you got to get into a 10 or 15 minute visit, but that's one of the main that's really important. When and how are you taking your blood pressure medicine? Or do you use one of those little things that you get at CVS on your wrist? Do you rest for 15 minutes before you take it? All those things are very, very important. Do you keep a log? If the log's intermittent and you get days where it's not taken, that may not be 100% reliable for the patient. Review their history again. So, do they have, are they on like things like Lipitor? So they may have arteriosclerosis disease. Their kidneys, they have kidney disease. Do they have, maybe those things have advanced in some way that's also causing it. So you could look at their diet or look at their salt intake or look at some other things. Ethnicity, like we always talked about, it's very important. Asking about their diet. Have you really been working on your diet? Or are you just kind of, still eating cheeseburgers and high amounts of salt? And BMI is very important too. So higher BMI, more capillaries, more force through the body, higher pressures, all those kind of things. A lot of times patients just lose weight, their blood pressure comes down. So it's kind of nice. So always consider those type things. So approach, how many medications are they taking? Are they taking one? Are they taking two? Are they taking three? Does it have that diuretic in it? And they're compliant with it and it's optimally used, then they're resistant at that point. And again, are these medications the most efficient based off of their history and ethnicity? So am I covering for their diabetes? Am I covering for their CAD? Am I covering for, their heart failure? Am I doing the right medications for this patient? Have they been compliant with taking the medications? When's the last time I did any recent or lab work or diagnostics? Based on my physical exam's not showing me anything. Maybe I should get some lab work to see the extent of what's going on. Or maybe I do hear a murmur now. Maybe I should get an echo. So those kind of things are really important to try to figure out, maybe I can dial this in a little bit better or find a cause for it. And also looking for secondary causes. Just questioning. I always have a headache all the time. A person will tell you their blood pressure is high and they have headaches. Well, maybe that's not necessarily due to their high blood pressure. Maybe it's due to something else, and they get palpitations. They can't sit still. They're anxious. Maybe they have thyroid issues. Maybe they have the pheochromocytoma, which is extremely rare, but those kind of things you really should look at. Exclude pseudo-resistance and secondary causes, especially when you're treating these things. So pseudo-resistance are all those things we talked about before, things that can mimic resistance that are not necessarily addressed. So ensure that they are keeping that low sodium, they're working on their diet, they're getting good exercise, and they have that optimum 3-drug regimen. That's really important. That's number one. That's what you really should make sure. And like I said, so resistance is that 3-drug and includes a diuretic. That is where you kind of fall into the resistance and you've ruled out all those other causes. That's a resistant hypertension that you would follow into the next following steps. So the good one, the first one is, so if you say you got a thiazide diuretic on there, so you got hydrochlorothiazide, is replacing that with a longer acting diuretic. So chlorothiazide, that's a really good one to put in there. It's longer acting, 25 milligrams. You still worry about electrolyte imbalances. May cause hypokalemia, but if you're on an ACE inhibitor, maybe they might counteract each other. So other things are, if the patients, you also got to look at their history. If they're on other medications, they may lower their sodium levels or something, say maybe like a Tegretol or something like that. You got to really be cognizant of it. But that's something what you can do is adding a longer acting diuretic. Patients with gout, you got to really be cautious with it, especially with the elderly patients, not so much for the gout, but just having that loss of any kind of electrolytes in an elderly can cause arrhythmias. It's a good medication, doesn't really have any hepatic, but you may have to change some renal renal dosing if they have dosing or renal issues, and caution with sulfa allergy because it can flare with that. I've never used this before, Lozol, but that's one thing you can do. It's kind of in the same thing. It's a longer acting diuretic. It's a little bit more expensive, but does require some renal dosing changes as well. But it's something you can add on top of these medications. Typically, chlorothalidone, that's where I go. Usually after that thing is I take the thiazide diuretic and I replace it, and that kind of monitor at that point and see if it helps. Next, what you do is you add something like aldactone. So that's more of a diuretic, so a spirulactone. It's potassium sparing, so you need to monitor with things like an ACE inhibitor or an ARB because you want to make sure those levels don't go higher. You want to watch that, and you may need to do, blood work in 2-3 weeks or something like that just to make sure. Hyperkalemia can cause renal impairment and other things. So if they have renal impairment, they're going to be more likely to hold on to potassium as well. You want to avoid the patients with Addison's disease. I personally have never treated a patient with Addison's disease, but it's something to be aware of. I have seen patients acquire gynecomastia from this medication, so it's something to watch out for at that point. Inspira, same thing, caution with heart failure, but it's way more expensive, but it's something to consider as well. You definitely have to consider both hepatic and renal dysfunction when dosing this medications. So it's something you probably have to follow up with UpToDate or something otherwise for that. Next, you can add another beta blocker or a combined alpha blocker. So if you don't have Toprol on there, you can add it, especially if they have CAD or an MI or others. You can consider adding diltiazem if they have a history of COPD or AFib. That's something you can add on top of it. Another one, though, is you can combine beta-1, beta-2, and alpha blocker, such as labetalol or carvedilol. Those are the ones that you can add on top of that. These patients usually are already on something like Toprol in the beginning, but switching it out and adding it for something like labetalol or carvedilol may be a way of bringing down that pressure a little bit more effectively. In the meantime, if it remains extremely high, that's when you can start thinking about maybe some of those centrally acting medications like clonidine, the weekly patches versus oral. But just always remember those need to be tapered down to avoid that reflex hypertension. If they have CAD, you really got to watch it, but it can also cause sedation in some way. Now, if it's really, really high, things like hydralazine and stuff may be a good thing too as well, depending on what their history is. So you give them that, and it's still not coming down. They're on labetalol. You always, again, want to look at secondary causes and try to figure out. You can think about hydralazine, especially with heart failure because it's with the afterload, but it's something that can cause blood pressure to drop down. It's not very long acting, but it can drop their pressures down, maybe increase their risk or decrease their risk a little bit. It can cause a lupus-like syndrome. I've never seen that before, but they talk about myalgias and fevers and rash type things that it can cause. Patients with CAD, you got to be really careful because it can cause angina type symptoms, MIs, and like we said, one of the main side effects with this is tachycardia that you can see quite a bit. And with really advanced renal disease, you really want to be cognizant of that. And there's isosulfide if they have a history of angina. This really works well because it's that long-acting vasodilator that can help with that, but also help keep their pressures down. So that's always a good option as well. And all of these depend on their history. They're very patient-specific, and even getting some kind of consultation is always a good thing in between these steps. And then that's where I get in the step 6. So if it still remains high, you always look at your differentials. You reconsider potential secondary causes again. What am I missing? Why does this person still have such a high blood pressure? And you reevaluate for those things, lab work, imaging, whatever you need. But if it still remains high, there's sometimes you just got to reach out to some form of specialist to get their secondary opinion, because maybe you overlooked something, maybe you didn't think about something, but there's always a good idea to consult with someone else, especially with cardiology or something, to try to get another opinion on what's going on. This is a great flow sheet. It kind of goes over exactly what I just talked about. It's found on UpToDate. It's a good thing to kind of keep maybe in your office or up on the wall or such, just to give a kind of a flow sheet of where you can follow. I use it in here quite a bit. If the patient's blood pressure still remains high and there's no exact cause for it, I usually use this algorithm quite a bit. So that's a great thing. And that's it. And so I hope that was educational. If you have any questions or anything, please reach out to me. Again, I'm honored to be here delivering this lecture again, and thanks, or not again, but giving a second lecture here at APP to APP. I think it's a great program. I think they offer some fantastic information and have some great speakers, and I'm honored to be here to talk to you guys today. And I've included my references at the end. So I hope you all have a great day, and thank you for listening.